and we are going to get started this afternoon. Vascular. We have Dr. Healey. He's a board-certified vascular surgeon with extensive clinical expertise in areas of vascular surgery, as well as significant experience in research and medical education. Christopher began his vascular surgical career in 2007 in Portland, Maine. He has served as an assistant professor of surgery at Tufts University School of Medicine. In addition to having a busy clinical practice, his research activities include being a local principal investigator on multiple clinical trials. Christopher joined the Vascular Care Group, practicing primarily in South Portland and Mercy in July of 2023. Pleasure of introducing.
Thank you. Thanks for having me. This is not my typical audience, so I'm going to try to do my best to give you a good talk. Valerie Fuller kind of invited me. I worked with her for a number of years. I don't know if she's in the room, but I think a lot of you guys know her. And she said, well, what do you want to talk about? And I said, well, I could talk about like the most common vascular consults. And then I started to do that, and that was going to be way too much for an hour. So then I kind of picked one of them that I thought perhaps you see the most of, and one that you could potentially have the most impact on patients. And so I selected peripheral vascular disease. I'm going to start, and probably all of you know this, but if I go to a party or I go to an event or I'm at somewhere and someone says, what do you do? You're a vascular surgeon. Oh, you're a cardiologist. Well, no, so what is a vascular surgeon? A vascular surgeon, my quick answer at a party is anything that's blood vessel that's not in the heart and the brain. And I think there's also this kind of thought that a vascular surgeon just does big, horrible, horrific open surgeries that take 12 hours and amputations and the like. But I'd like to think that we do more. We are diagnosticians and we prescribe medical treatment. We do reconstructive big open surgeries, but in the course of my career, since I trained in the 2000s until now, the incisions I make have gotten smaller and smaller and smaller and smaller, bordering on non-existent. So it's changed what we've done. We do kind of inpatient and outpatient work. As I transitioned into my new practice, I do a lot of stuff outpatient that I couldn't have imagined doing when I was a resident or even a medical student. We're pretty good at imaging. So if you have vascular imaging questions or concerns, you can reach out to us with that. We're good at ultrasound, CTs, MRIs, and the like. So what I hope to get to is why peripheral artery disease is important. Kind of go through what I imagine you see in the primary care doctor and when you might be thinking about making a consult to us. Make sure you know who to look for, and really try to engage you to kind of help care for these patients and send them to us with good expectations and send them to us so that you've already started the ball rolling with what's going to happen, and we can back you up, so make you look better, but also have them prepared when they see us. So this slide is more of an atherosclerosis slide. You could have this same slide and be talking about carotid disease. You could have it talking about coronary disease. But it really is a progressive disease that, in med school, they would show us pictures of pathology of plaque in a 20-year-old aorta and a cadaver, and I didn't worry much about it. But now that I'm in my 50s and I might be towards the right side of it, I worry more about it. And I think the thing that's kind of telling about this slide is as you look across the increasing severity of this disease, the real challenge is it doesn't usually bother anybody until they're way over to the side where they're near occlusive. We can compensate very well. And so often by the time I'm seeing them, and often by the time you might recognize, they're towards the end of that spectrum. So I think the challenge is trying to, particularly in your seats, identify it and halt it before they really need us. And this is, again, just another pictorial way to describe what ultimately happens. So PAD, much like that progression that you see as the pipe was getting more and more clogged, is a spectrum of symptoms. I'll show you the next slide. The majority of people are asymptomatic, that you may be able, I think the best you guys could do is if you can identify asymptomatic people and modify their risk to stop them from going down that progressive worsening of disease, that's where you're going to help the most. Claudication is simply pain when they're walking, but not at rest. And then the last kind of part of the disease spectrum is pain at rest or ulcers or tissue loss. this is an old slide that I had, and so the numbers are probably not accurate, but I think probably the percentage is no different. So this slide says of 10 million people, 5 million are asymptomatic, and I think that probably holds true. Probably 50% of people that have peripheral disease are asymptomatic because they don't walk far enough because their back or their arthritis or their breathlessness or so forth. Others are symptomatic, but they think it's their back or their hip or something else that's causing them not to be able to walk. And then there's a small portion, so probably out of 100% of people that have the disease, only 12% are getting treatment in some way, shape, or form. I'm going to talk a little bit about medical treatment, and I think that's where you guys could help us a lot. I think in the course of my career, even like the use of aspirin used to be kind of pervasive. We thought everyone should get it. And then now it's like, well, not everybody should get it. There's some bleeding risk, but vascular patients should. They remain a group of patients that should. So, trying to identify that 50% of people are asymptomatic, like when you're doing your counseling on should you be on aspirin or not. Am I wrong? Now you don't tell everybody to be on aspirin, right? If someone is diagnosed with vascular disease, do you change your tune? I think probably it should, and years before everyone was on it, so it was not as big an issue. But here, I think it's important that you actually get them treated. It probably affects, I think, a quarter of the U.S. population, but maybe it's not causing them symptoms. And being in Maine with our age distribution, you're going to see it more than someone in other states that are more younger and vibrant and don't smoke as much and are more active. As we get into the 70s, it's probably well more than a quarter of the patients you see have peripheral arterial disease. So why is it important to find it? Not so much to send me all the claudicants in the world or the consultations, but to try to, again, halt that progression before it gets to the point where they need surgery. It's a very morbid condition. And if you look at people who present with MI or peripheral disease or stroke, the mortality is higher with peripheral arterial disease than it is for someone with an MI. Some of that, I think, may be related to when you have an MI, it kind of rocks your world and shakes you. And so I think patients make changes when they come into contact with the medical care and they have an MI. Someone comes into contact with claudication, they don't necessarily make changes like you do when you come in with crushing chest pain and get a coronary stent. I think you guys, I'm sure you all know who to kind of look for, but in your busy clinic, I don't know how you do it because you're trying to take care of every medical problem at once. I only have to take care of really a handful, but trying to identify it in the right people, older, male, family history, high cholesterol, high blood pressure, but really diabetes and smoking. If it smells like that when you go in the room, they probably have peripheral arterial disease. If they're over 50 and they're a man and it smells like that, you probably want to screen them in some way, shape, or form. So the evolution of the disease, kind of skipping asymptomatic, probably the majority of patients you're going to see are going to be claudicants if you have symptoms. And then you're going to see people perhaps with rest pain, which there's a very fine line between rest pain and getting an ulcer. So that's another play. I think trying to identify claudicants and asymptomatic, get them on medical treatment, but then trying to find, if you identify someone with rest pain and get them to us before ulceration, that's an awesome job and probably going to save some limbs. So that guy's kind of holding his leg. That's kind of the typical claudicant. That picture is what I would consider minor tissue loss or minor ulcers related to, and that's where we'd really like to see him in a hurry because that's reversible. And they might lose a toe tip, but that's a victory relative to a transmetatarsal amputation or a below-the-knee amputation. So actually preparing for this, I was always taught that it was claudication is too limp and it's just from Latin. I didn't know that there was an emperor named Claudius who for some reason used to walk short distances, stop and stand before going again. He probably claudicated. I thought it was just a Latin translation, but apparently there was an emperor named Claudius who claudicated back in the day. Overall, this can be debilitating, but it's not particularly dangerous. I think this slide is important in the sense that most of the symptomatic people you see are going to be claudicants. And the reason I want you to identify it is to try to shift the balance as far as their cardiovascular morbidity and mortality. what I'm trying to get at with this is that a claudicant, when you just look at their limb, 80% of them will remain a claudicant for upwards of 10 years if you do nothing. A small portion will get worsening claudication, and a very small portion, so over 10 years, only a couple percent will actually progress to critical limb ischemia. But 15 to 30% of them are going to have a cardiovascular event, and also 15 to 30 are going to die from a cardiovascular event. So the reason to identify the peripheral arterial disease in my eye is partly to maybe treat it, but more importantly to try to use it to catapult them to make changes and to get their medical treatment right so they don't have the cardiovascular event, fatal or non-fatal. So my push to identify it is equal parts. I'd like to make people feel better. I want to save limbs, but probably humbly, more importantly, if you can identify it so they don't die from their heart disease, or you can use it to convince them to make changes so that maybe they won't die from their heart disease. So if you see someone with claudication, this is where I think it's helpful to kind of partner and have you guys say the same thing we're going to say when we see them in consultation. I imagine when you're in your busy clinic, if you find something like this, you're probably, okay, claudication, just send them to vascular. But if you can start the ball rolling on the counseling. So when we see someone with claudication, the first things we're going to try to do before we put stents in or do bypasses or the like is try to medically optimize them. We're going to try to get them to stop smoking. We're going to suggest they get on a statin, get their A1C right, get on aspirin, Plavix if they can, maybe try a Pletol, and then lastly, talk to them about an exercise program. So if you see a consult and you say, we think you have claudication, we're going to send you a vascular surgeon, you could say, here's what they're going to tell you, and here's what you need to start doing. They may be able to help you with a procedure, but first things first. You got to work on your smoking. You guys do this all the time, but I think hearing it twice, I think sometimes people show up, they said, oh, I thought you were just going to fix it when they come for the thing. Like, aren't you just going to fix it? And I have to go back and say, no, this is a systemic disease. We can treat some of your symptoms and we can make you feel better. But together with your primary care doctor, you now have a disease that's a chronic lifelong disease. And if you don't do X, Y, and Z, the procedures I do don't work well. So I guess if you're having that discussion where I'm going to send you to vascular surgery, I encourage you to say, they're going to try to make you feel better, but we got to work together to get your disease under control if what they're going to do is going to work. Is that how you think about it? Or is that what you think a vascular surgeon would say? Or I don't know, anybody? Kind of. But I feel for you guys, like you're talking about their obesity, they're smoking, like how do you do all that? But I guess I would just engage them, as we can hopefully work together with you guys, help with the medical part and continue to reinforce that while we potentially consider interventions. So I think you probably, you send us claudicants, and I think if I was on the other end getting the note back, I'm like, well, when do they actually do something, and why did they do it to this guy and they didn't do it to that guy, and why did they do it to this person? I think what we try to weigh is that our procedures are not as good as I would like them to be. They're not altogether that durable for claudicants, and we take a little risk when we intervene on a claudicant that we take something that has a pretty benign natural history and we could make them worse. So, like I said before, 2% of people who have claudication will progress to critical limb ischemia in 10 years. If we have a complication from something we do, we then took something that was fairly benign and we made it limb threatening. I also think when I think about that, those only a certain small percentage progress to critical limb ischemia. Some of that is because they die from their heart disease too. So it's a systemic disease that we put our finger on different holes, but we don't really fix. And so when we're talking about a claudicant, it's very individualized, and we try to pick procedures that are lowest risk and highest yield in combination with people that are kind of committed to doing the other things. If you're uncommitted to doing the other things, our reintervention rates and our failure rates are so much higher in someone who is smoking than someone who's not smoking. I actually push pretty hard to get them off completely before I'll do an intervention for claudication. If they have an ulcer, no, because they're in danger of losing their limb. But for someone that's claudicating, I try really hard, and it almost makes me feel bad when I book someone who's still smoking that I haven't done a good job. But like, there's one guy who he's got some psychiatric disease and he's been coming to see me for like a year. And every 3 months I give him hell and I say, you got to stop this. And he's taking his medication. I'm trying, I'm wearing the patch. And he said to me, he says, some of it is because I can't walk, I smoke. What do I say? I'm like, all right. So, but he convinced me that if I could help him, it would be that last thing to get him over the hump. So I wouldn't say like, I like some of the joint surgeons will say, I'm not going to do it until I'm off smoking. We're fairly vigilant, but maybe I'm a softie. In that predicament, I'm sitting there face to face with the guy, and he's like, "Look, part of why I'm so anxious is because what I like to do is walk, and I cannot." And so I sit there and I grab a cigarette. He's like, "I'm pretty sure if I could walk, I would do it less." So I booked him for an angiogram. We'll see. Um, so I'm just going to stick a couple of real cases from the last 3 or 4 weeks. And this may be not the best. It was just recent. So this is a 66-year-old guy who's a former smoker, and he presents with exertional right leg pain. He says he can go 50 yards, and then he has discomfort in his calf and his thigh. Been going on for more than a decade. So he was symptomatic for a long time and not getting treatment. He also has a bad back. So he has chronic back pain. And so for years, he'd been treated that way. Recently, he was getting physical therapy for his back pain. And his physical therapist said, you know something? I've been working with you for years and you're not getting anywhere. Maybe you have vascular disease. And so his ankle-brachial index, which I'll get to in a little bit, was 0.5 on the right side. It was 0.94 on the left. And I couldn't feel femoral pulse on his right side, which is consistent with when someone describes kind of buttock, thigh, and calf claudication with more proximal stenosis. Also, I find that kind of iliac disease is harder to differentiate between like neurogenic claudication because it affects kind of the whole leg, and sometimes they describe it more like fatigue or gives out than your classic calf claudication. So he hadn't been smoking, he was on the right medications. Basically, he tried an exercise program because he'd been working with PT. So I said, let's do an angiogram. And so this actually, like, this is one of those things, like I said, I couldn't imagine doing. We do this in our office. We have a procedure room where we can do angiograms. So his right leg is the problem. I punctured his left femoral artery and put a catheter up and over. And this area right here, and sorry, it doesn't come that well, was where he had a pretty significant stenosis. And this is post-stenosis with a stent in it. He was exceedingly grateful. But he was the type of person that I think the type of claudic you should treat. He was trying to exercise, he was medically optimized, and I think he's going to do real well. And an iliac stent, 5-year patency is like 70%. An intervention on a tibial artery, the 1-year patency is like 30%. So that's where you want to pick what's going to be low risk and high reward. So on the spectrum from asymptomatic to claudication, critical limb ischemia is pain at rest when you're not walking. It usually occurs at night. It'll often lead to them sleeping in a chair. It'll often lead to them saying, it hurts so much, I just hang my leg over the bed, or I have to get up several times. And then ulceration or sores, like the picture I showed you before. This is one where you could call, if you think you have this, call us and say, look, you got to get them in a week. You got to get them in fast. This is much more urgent than claudication. Claudication is not urgent. And claudication, I would encourage you to engage that risk factor modification. If you see this, say, you got to get in there, you're in danger of losing your leg. You still got to do X, Y, and Z, but you can put the fear of God into them. The mortality and the morbidity of critical limb ischemia, so going from claudication to where you have ulcers or rest pain, is drastic. It's a marker for a heavy burden of disease. So if you've gotten to the point where you have critical limb ischemia, you are way over to the right side of that graft of the arteries where you're near occluded. You typically have to have occlusion or near occlusion at multiple levels. So if someone has a superficial femoral artery occlusion from their groin to their knee, they'll claudicate. It's when they have an iliac stenosis and an SFA occlusion and tibia disease. So it's a bunch of occlusions kind of lined up in a row. But if you look at the natural history of people with critical limb ischemia, in 6 months, 20% of them are dead. 40% of them are alive with an amputation and 40% without an amputation. So that's pretty miserable. And kind of, I think, just gets back to my first couple slides, like, can we stop it before they get to this? And it's hard in a rural state where there's lots of old people and smokers who don't get care. So keep doing the best you can. So this is a classification system that kind of just puts into kind of a grading scheme the spectrum of where we're at. So asymptomatic, mild, moderate, severe claudication, ischemic rest pain, minor tissue loss, and then major tissue loss. So someone with major tissue loss, there's someone, like she was telling me, comes in their office and their foot's black. It's too far gone. We might not revascularize them. 5 is that is kind of the sweet spot for trying to save a foot that's at the little toe wounds. Those are the ones that we'd like to get before they get into deep trouble. She mentioned I did a little bit of research. One of the projects I was working on was a stem cell project for non-reconstructible disease. So they had to have critical limb ischemia, so not for claudicants, but wounds or rest pain on their feet, and have been evaluated by a vascular team who said there was nothing we have left to do. So then we would aspirate bone marrow, spin it down, and then do this platelet-rich injection along where the blood vessels are supposed to be, and it was allegedly going to help them develop collaterals. It wasn't a positive study. I've learned a lot from negative studies. But one thing I did learn from it was that when I was brought up through vascular surgery, we were kind of taught critical limb ischemia, like rest pain and ulcers were the same, but rest pain's not as bad as having the ulceration. In fact, we did now I can't remember the first little small number trial, and not enough people with the rest pain were losing their legs in the control or the treatment group. So we couldn't tell a difference. So then we only included people with ulcers. So ischemic rest pain is often lumped together with tissue loss, but it's probably not as virulent as the tissue loss. So diagnosis, how do you make it? History. I think the most challenging thing in the history is their comorbid illnesses. So many are obese, many have arthritis, many have back pain, many have neuropathy, many have venous disease, many have heart failure, many have swollen legs for other reasons. You can't feel their pulses because they have swollen legs. It's not easy. Sometimes when we grumble amongst ourselves on our clinic, they send us all this stuff. I'm like, well, you know, try sorting it out. Like, we're seeing a self-selected population, and it's hard for us to diagnose it. So I hear you, do the best you can, and I understand, but physical exam is helpful, but there's a lot of things that can mess with your physical examination. These are classic findings. So cool extremities, hair loss, poor nail growth, dry skin. This picture is kind of classic dependent rubor. This is something that we'll get consulted sometimes for cellulitis, and it can be confused for dependent rubor. Have you heard that before? Yeah, and so you guys know that. I hope I'm not talking down to you. I wasn't sure where to level this, so if you say this is too easy, we can stop and just do questions too. But the way to kind of clean this out is it's cold, it's not hot. That's the key. And if you have them lie down and lift it up, it goes white as a ghost. So that foot that looks red, you lift it up and it is cold and white. And then you know you got it. You got that, call our office, we'll get them in fast. If you think you have the diagnosis, where should you start? It depends on your local availability, depending on how rural you are. You don't want to send someone to South Portland who's claudicating maybe just for an ABI. So hopefully you could get an ABI locally, and then you could start medical treatment, have them walk if they stop smoking and they really are lifestyle limited, then get them down, because it's such a vast state. So I think as a PCP, having a little familiarity with making the diagnosis, particularly in the non-critical limb ischemia, so you can start managing close to home or just keep it close to home if it's fairly benign. So you all know what this is, but that's the practicality of how you do it. One thing that's important, I just got a consult that when you report an ABI as a radiologist, you take a brachial pressure and then you take an ankle pressure, both at the PT and the DP. And the way it should be reported is with the higher of the two. Because if you have trouble with your DP but your PT is normal, you're not in any danger of anything. So this person had an ABI 0.95 when they measured at the posterior tib, but 0.5 in the DP, and they reported it as moderate disease. but really it's not. They have disease, but it's not moderate because if you have one vessel going down that's normal, you're good, you can heal. The trouble that ABI is far from perfect. So if you are worried and clinically you think they have the problem, but the ABI is reported as normal, don't stop looking because you can be fooled. If it's less than 0.9, it's good at predicting it. If it's not compressible, which the diabetics are famous for, it's a crap test. So if it's more than 1.2, think that it's garbage. If you have a foot that looks like you just saw, or you have a wound, think it's garbage. I think it's more helpful almost more helpful in claudicants, or when it backs up what you already think. But if it doesn't back up what you think, don't give up. Keep looking. So this is kind of a step up from an ABI. This is segmental pressures and waveforms. All vascular labs can do this. Not all radiology departments can do this. I think, you can talk to your local radiology department. Some can do ABIs, but not all of them. So I guess my thing to do is go contact where you would send patients and see what they can do. They'll have something. I find this helpful. Basically, with all those cuffs on the leg, it gives you pressure measurements at each level. So it can give us a sense of whether it's iliac disease, femoral disease, SFA disease, popliteal tib. It kind of starts the ball rolling without giving them any radiation and without giving them any dye, which if we can avoid, a lot of these people have CKD. So if we can get more information before we get to the stage of giving them dye, it's helpful. Those non-compressible ABIs that are like 1.2, 1.3 in the diabetics, if you have an ulcer, a toe pressure is a valuable tool. Many places don't have this available. I find this very useful. For some reason, if you can't compress an ankle vessel, the toe pressure can still give you an accurate measure and also help you predict healing. If you get a toe pressure more than 70, you're going to heal. If you get a toe pressure more than 30, you probably can heal. But if you have a toe pressure less than 30, throw out everything, you're not going to heal. And that's when we definitely need to do something. Let's see. Questions? And if you get reports, there's a whole bunch of crap on there. But this is the blood pressure greater than 250. So if they say that, you're wrong, you're in trouble. But the toe pressure can often be helpful. So in this person, a toe pressure of more than 70 and a toe brachial index of more than 0.3, if they had a small wound, I'd probably say they can probably heal with what they have. Do good wound care, do good offloading, come back in a couple weeks. And if they're not, I might consider an angiogram. So this is a good screening test to help me decide, am I going to expose them to the risk of contrast, et cetera. If they have a toe pressure that predicts they'll heal, I won't do it right away. If they have a toe pressure that's less than 30, then they're getting an angiogram as soon as I can do one. This is where it's the ball's in your court to find these people and get them to us. If you look nationally, this is a little bit old. I don't get the sense that it's changed though. The amount of people in this country who lose limbs without even getting a shot is mind-blowing. And I think some of that is there's a dearth of that. In New England, we're lucky, and in Maine, it's a little spread out, but you can get to a vascular surgeon in Maine with a less than a 2-hour drive from almost everywhere. There's pockets of the country where there's not that care. So people get advanced disease and they never even get an angiogram to look. So again, if you can find it before it becomes that black foot where the toes are falling off, that's where we'd like to see it. I'm sure that's where you'd like to find it. And if you have someone with a wound and you're not sure, I'd rather see someone who doesn't have arterial disease with a wound than not. And I'd like to do some negative angiograms, not because I want to do negative angiograms, but I don't want to feel like somebody lost a leg without me trying. So some of the local radiology departments won't have ABIs or TBIs, but all of them will have ultrasound. And so that can be helpful. And it's actually a little bit less likely to have false negatives than the ankle brachial indices. It's a longer test, requires a little more skill, and is a little more costly. But again, I'd encourage you to go where you would send people and say, what do you have? Like if I'm trying to find this, what do you have and what can you get quick? And ask the local expert what's the best test in this community? Because it's going to be different in different places, depending on, it's hard to find a vascular tech, even in our, so I imagine it's hard to find a vascular tech elsewhere as well. But I find this very helpful, particularly in patients with chronic kidney disease, because you can get a ton of information without giving them dye. The other thing, because we're doing a lot of percutaneous procedures in an outpatient setting, the more information I have, because we're pushing the envelope doing it, you only have so long that a patient's going to put up with you under local, and laying flat and so forth. So, like that fella, I knew that he had the problem in his iliac, and I knew where it was based on ultrasound, which impacted where I was going to puncture him. If the lesion was very close to the common femoral hair and I punctured here, I would have struggled. So I knew because of ultrasound which way I was going to go. If I just couldn't feel his right femoral, said, I'm booking you for an angiogram, I might have started here, and then I would have been, and he would have been uncomfortable. So this helps me a lot. The other thing is that I'll show you another case later where if someone has disease below the knee, a standard approach for us is to puncture the opposite femoral and do what I did with that guy, go up and around and do our intervention. But if someone has a creatinine of 2, getting from here to here, if you know that they're normal, is kind of a waste of contrast. So sometimes we can puncture the foot if we know the disease, or we can puncture the femoral antegrade, so facing the other direction, and save that workaround. So for me, I use duplex to try to really plan my intervention to minimize how much I have to figure out on the fly and to minimize how much contrast I have to give. If you don't have great access to non-invasive like ultrasound, MRI, CTA can be helpful. MRA, I find, is hard to get a good one, takes a long time. So I suspect wouldn't be a practical test for you, but it gives you beautiful pictures. The nice thing about it is there's no contrast. I would say CTA is probably, after ABI and duplex, the most common modality that I use in my day-to-day. Where I use CTA is in people who have what I think is significant inflow disease from the femoral up. Because and the other way I use it is if I mentioned we try to pick the smallest procedure with the highest durability. Sometimes me and the patient are on the fence as to whether they want to do something. I'll say, why don't we get a CAT scan? Because that, again, can give me more information. If the anatomy says you need an aortobiofemoral bypass, you might think your claudication is not so bad. If your anatomy says you could have a 45-minute or an hour procedure where I put a stent in, suddenly they may be more inclined to proceed. So a CAT scan can give me, I would say, more detail than an ultrasound, and sometimes helps me to counsel a patient as to what the risk would be and what the extent of the procedure would be before we get to doing an intervention. So this one in the middle is a picture of someone who's basically got an occluded superficial femoral artery. So that's common femoral, this is deep femoral, and that's where the artery comes back. This one here, it looks like kind of a flush occlusion, so you don't really see the superficial femoral at all. That anatomy, if someone was a reasonable bypass candidate, that looks to me like more of a femoral popliteal bypass candidate. This one here, this is the superficial femoral here, and it's just occluded for a little short segment. Because it's not occluded right at its origin, it's a shorter segment. This is something that I would try to treat with a stent. If I was going to approach this, I would probably puncture the right common femoral, go up and around, and then put a stent or angioplasty or right in this mid-segment of the SFA. So I didn't want to get in the deep weeds about how we think about it, but I think kind of telling you a little bit is probably hopefully interesting, keep you awake. There are the other kind of interesting thing that I'm not sure I even understand is there's different patterns of disease in different people. So for some reason, the early onset smoking, heavy smoker atherosclerotic population tends to get really bad aortoiliac disease. Diabetics get very bad distal disease. So it's and the diabetic distal disease is much harder for us to treat. So this seems more typical of a younger smoker. SFA disease is also kind of younger smoker, but diabetics, they'll have like a completely normal angiogram all the way to their knee, and then disaster. And physiologically, I don't know why that is. I don't think anyone does, but it's well recognized. And unfortunate, I always kind of feel bad because the people with aortic SFA who've been smoking like fiends, we actually can fix those pretty easy. Diabetics who haven't been doing that, sometimes we can't. So again, it's a spectrum both in what the disease is and a spectrum in what the invasiveness of the treatment is, from medicine to exercise to a percutaneous puncture to a big surgery. I'm kind of going back and forth to the same things just to try to keep your attention to what we need to. The one thing on this slide, and I think this is in the Journal of Cardiology, but it was about peripheral vascular disease, that I hadn't included before is DOAC. So there's actually a pretty good paper in the New England Journal that looks at a peripheral vascular. Is anybody prescribing a DOAC for PVD at a PVD dose? Once, yeah. So there's not multiple papers, but there's one very well done study that was in New England Journal that supports a lower dose DOAC in people who have had previous peripheral vascular interventions, a little bit to support their interventions, but more so actually with a mortality difference. It's only one trial, so, and I've had a hell of a time prescribing it and getting it paid for, which I imagine you guys deal with AFib. Do you have trouble getting it for AFib or no? Not usually. It seems as if it does have a PVD indication. It is a lower dose. I think it's 2.5 BID. But I've had trouble getting it for people, although I hope that more data accumulates, because that one paper I think is very compelling. So if someone comes back after intervention and they're on the DOAC, it's because it's based on that data. I think it's the Voyager trial, I think. But the statin and aspirin, everybody, smoke and exercise, everybody. But the DOAC is something that I actually hope we're going to see more of, and hopefully they'll start covering. But I think it's less than 50% of people that I try to give it to seem to be able to get it, and almost nobody can get it. Maybe I should say they have AFib. I hope you guys are better than me at smoking cessation, but I think it's an important part of being a vascular surgeon, and if you're not doing it, then you're not really doing your job. If they're able to stop, they're very unlikely to ever get to critical limb ischemia, and if we do something, our results are much poorer if you can't get them to stop.
So clarifying question.
Yeah.
When you say smoking cessation, do you mean nicotine cessation, or can I get a patch on them, but that still causes restriction? So
Smoking cessation. If you get a patch on them, eventually they'll get the patch off.
I need to have to treat the addiction, so if that means they're on a nicotine patch for the rest of their life after smoking, I'm okay with that.
Yeah.
But it's still a vasoconstriction.
Yeah, I guess I'd like them to someday get the patch off if they could, but I'd rather have them a patch on than smoking. Especially like, I'm always like, I try all different conversations. Like, I'm always baffled. How do you afford it? Like, it's like $7 or $8 a day, and or more. But I'm also shocked at sometimes that, oh, I just roll my own. I'm like, oh, that's even worse. They just get bags of tobacco and roll them, and God knows how much they're getting. But I liberally refer to the helpline. I hope you don't mind. I offer them Chantix from me, even if they didn't take it from you. I think that's I think if I can get someone to stop smoking, I'm probably doing more for them than if I put an iliac stent in. And that's where if you started it and you said, look, he might be able to fix you, but he's not going to let it. He's not going to do it. Maybe they keep hearing it. And it's also amazing, like they likely will never get in that situation where they have tissue loss. One more slide to slam home how bad critical limb ischemia is. This is just a different way to say it. If you think they have critical limb ischemia, don't feel afraid to push us to get them in fast. because they should. Their prognosis is abysmal. And if you can catch them before, catch them before. Am I going way over? Okay. So what are parts of when I consider intervention? Some of it is like you want to get them healed because wound care is painful. The amount of money spent in this country with wound care is absurd. And if you, I work part-time at a wound center half a day a week, and those people, they have tons of patients with lots of wounds, and it's hard to glean out who has vascular disease. But if you don't take care of it, they often don't lose their leg, but they'll be going to the wound center for months and months and months and months and months. So if you have someone that you know is just like in the wound center all the time, and double check that they've been screened, because the wound providers are awesome, but they're overwhelmed, and sometimes you just get tunnel vision. You see them once a week for 3 months, and you think you felt the pulse the first day, but you haven't really thought about it in 3 months. So if someone comes back to your clinic and I've been going to the wound center, it's not really getting better, it's okay for you to, maybe you got vascular disease, and don't presume that someone else has checked. So the therapeutic goals of what we're trying to do is we want to get rid of pain, heal wounds, save a limb, keep them walking, minimize their cardiovascular morbidity. That's where I think I really need your help. But it's not as simple as just fix claudication. We want to try to look at all of these things. I'm getting too repetitive here. So how do we do it? Endo, bypass. Choice of therapy depends on, I think, the age of the patient, the anatomy of where it's occluded, whether they have a vein to build a bypass, how disabled they are, their longevity. So these are some, again, different patterns of disease. So this here is someone who has a complete occlusion of their iliac. So this is aorta, that's the iliac bifurcation, and kind of a complete occlusion of the iliac. This is more of the diabetic disease. So this right here is the tibia. So that's the flare of the tibia. That's the fibula. So that's the popliteal. What you should see is the anterior tibial artery coming over here. You don't see it. This is the tibia peroneal trunk, which is very diseased. You should see the posterior tib coming over here. But the only named vessel I see is the perineum. So they have pretty severe tibia disease. That's a hard pattern to treat. This is one that we don't have great endo treatment for. This here, when I trained, would have been treated with a femoral to femoral bypass. So with a groin incision here, a groin incision here, and just route a piece of Gore-Tex or Dacron from one side to the other. As my practice has evolved, if this was completely occluded, but the femoral was open, I might actually make a groin incision on just the left side and see if I could get a wire through, and just stent right down into a femoral endarterectomy. So just one groin incision instead of two. This is your typical young smoker. This is your diabetic. This could be anybody. This is your knee right here. This is bulky kind of calcified plaque in someone's superficial femoral artery. That if they had that alone, they're probably just a claudicant. This could be bypassed, and early in my career would have been bypassed. Now it tends not to be, but we don't have a perfect stent for this. All where it's really shadowed out is hard calcium, and we're asking an awful lot of a stent to hold that back. So this kind of burden of calcified plaque might be someone that we try to atherectomize or roto-rooter to kind of decrease the compliance before we then stent. But there's it's different every day. I'm good at pattern recognition, but I see a different disease most days, which kind of makes it interesting. So surgical bypass, when you see a patient back, they may look like this. And so this is a femoral to tibial bypass. The saphenous, so there's two ways to make a bypass with a saphenous vein. One is to harvest the whole thing, disconnect it, flip it around so that the valves typically prevent flow from going from your toe. Keep it going from your toe up. So if you just disconnect it and sewed it in, the valves would prevent it from going down. So the one way to do it is to disconnect the whole thing and flip it around. The other way to do it is to leave it in place, and from the bottom pass up something called a valvulotome that is like a little hook. So you hook up the vein at the top, and then you disconnect to the bottom, you pass this hook, and you lice the valves. I do both you used to be, there'd be like whole meetings about which one was better. No one's proven that one's necessarily better than the other, although I tend to think that without reversing it, you have less of an incision. Even this is a little more than you often need, and the less incision, the better for these people. I tend to only reverse it if I'm doing one. So this one right here, you're going from the femoral to either probably the posterior tibial, which is on the inside aspect of your leg. If your only option for a bypass is on your anterior tibial, which is on the lateral aspect of your leg, it's hard to leave it in its natural position. So then you have to take it out anyway and kind of reroute it. But that's the typical incision you'll see after an in situ below knee tibial bypass with vein. It's a huge operation and it's morbid. You've probably seen people, but if they can get through that acute period, a vein bypass is more durable than endovascular, generally speaking. If someone has a good vein and someone can tolerate the procedure, there was a huge NIH-funded trial called the BEST CLI trial, critical limb ischemia trial. The two PIs were from BU, and they're kind of like my generation. It was incredibly well done, and it demonstrated that if you have an acceptable vein, it does better than endo. It's interesting, that's published 3 or 4 years ago, and they recently just looked at how treatment has changed with the results of that trial. Interestingly, more bypasses are not getting done. And some of that may be because as newer trainees are coming through, they're just doing more endo and they're not as comfortable doing bypasses. And so I think also, even though that trial says that, if you show someone a picture of that leg, a patient versus a puncture, even if it's not as durable, if you give them the option, nobody wants to have this, but I still do it. So here's a critical limit. I showed you that claudication case where I did an iliac stent. This is a 70-year-old guy who was first seen by our PA in our office and presented with rubor on his foot and these little kind of black eschar ischemic looking wounds on his foot. He had been claudicating for years and his PCP had him on the right medications. He wasn't smoking, and he walked regularly, and usually he could go 7 or 8 minutes and get calf pain, but very abruptly, he couldn't walk to the mailbox, and he started having this pain where he couldn't sleep at night. So I think he probably, if you remember one of those first slides where it was a high-grade stenosis and then there was one with plaque rupture, he did something. He had an acute change on chronic disease. So he went from disease to either completely occluding or having a plaque rupture, and he got into this. So he's one of the unlucky small percentage that progresses, but he did. So this is his ankle brace. I kind of cut out the ABI. So his left side, which was not really symptomatic, his ABI is 0.8. So like I said, when you report it, you should report the higher of the two. His toe pressure was 50 and his toe brake index was 0.35. So not normal on the left, but not at a point where you would anticipate that he would have tissue loss. The right side, which was the foot there, his toe pressure was 26, so less than 30, predicts he's not going to heal. His ABI was 0.5. So with this one, I actually punctured the opposite femoral and I put a catheter over. So this is right at his femoral head. This is his common femoral artery. This is his profunda, and his superficial femoral artery is supposed to be here and it's absent. So many people won't have horrible tissue loss with an SFA occlusion if they have a good deep femoral artery. But I think part of why he was so bad is, you can see this is the deep femoral artery, which is nature's bypass, and even it is diseased. So that compromised him. So I kept going, not knowing if I was going to do endo or open. So this is a continuation of this. So his SFA is absent, but then it came back kind of mid-thigh, and then it looked not so bad. So I was thinking to myself, well, if that's his only problem, I could stent from there to there. But as I kept going down, this got to his knee, and his popliteal completely occluded and occluded right up to the fork in the road for his anterior tib, perineal, and posterior tib. So he's fairly youngish, and he had a good vein. So I vein mapped him. His vein looked adequate, and I did a fem to posterior tibial bypass on him. He's only like a month out. So far, so good. So I showed you endo for claudication, a bypass for tissue loss. This slide is extremely busy. I don't know that it's crucial that you know all this, there are so many tools that we have in our toolbox that it's confusing to know which one to use. I'll be quite honest. And more come to market every day, and they come to market with little data. But I think globally, endo is less invasive. People like it better, but not as durable typically as open surgery. But it's right for more people than it's not right. So, you know, some of the we have. I don't use this much, but there's like a balloon that's like a cryo balloon, so it's iced, and that the whole bugaboo with these treatments is recurrent disease or recurrent stenosis, and some of it is at the site that you treated, and some of it is you're treating their SFA, but it's a systemic disease, so a year later their popliteal is occluded. So it's a little bit of a failure of our, and that's where I think bypass does a little better too, because you treat a longer segment, and you bypass the whole segment. But we have lasers to kind of ream it out. We have cutting blades that come from the side. We have spinning cutting blades. It ends up being, I think, the data is so mixed that you use what you're good at, you use what you're most comfortable with, and it is getting better. I was actually telling her for that tibia disease below the knee, right now most people will use a combination of atherectomy, where you kind of roto-root it, or just plain old balloon angioplasty, but the results are dismal, like 30% 1-year patency. Stents, people have tried coronary stents, but the trouble, the coronary stents, they're like that long, and the tibia disease is much longer. So they don't really make a coronary stent that can treat the tibia disease we want to treat. What I think is going to be the holy grail is a bioabsorbable stent, which are available now. So they're a scaffolding that if you take it out of the packaging and mess with it, it has the same kind of external force as a stent, but it slowly dissolves. So it doesn't have the foreign body reaction. And as it's dissolving, it's like releasing Paxil or an anti-inflammatory. So I think that might be, but it remains to be seen. Abbott just got approval for a bioabsorbable for below the knee indication, which is kind of exciting. This is kind of what a typical nitinol stent looks like. These are covered stents. So they're basically stents that have Gore-Tex wrapped around them. There's data in the iliacs that they have less recurrent stenosis because some of the intimal hyperplasia that can grow through those interstices gets blocked by the Gore-Tex. The trouble is they'll get intimal hyperplasia on each end. So where the ends are, we'll tend to get it. So we haven't solved it clearly. So this is critical limb ischemia. This guy's a real interesting guy, 77 years old, and he's a paraplegic, and he's got PVD, and he had a sore on his bottom, and the wound center was working diligently to try to heal the sore on his bottom, and he developed this on his lateral ankle, probably because he was trying so damn hard to stay off his bottom and going on the side. He got a pressure, and he created a different spot where he got pressure. He went to a different vascular surgeon who did an angiogram and saw that his popliteal was occluded, and didn't, I don't think, give him a bad recommendation. He said, you know, you have some collaterals, you might be able to heal with what you got, but you don't walk, you're in a wheelchair, you're not really a candidate for an intervention. So if it gets worse, you can have an amputation. I don't think that was bad medicine. And I don't know, I might've said it if I was the first person who saw him, but he came to me, and he came to me with a paper. It was like 10 people of critical limb ischemia and revascularization in a wheelchair dependent person. Like, really? And it was small numbers, but he convinced me. He's like, yes, I know I don't walk, but I use this for certain maneuvers when I'm transferring, and quite frankly, mentally, it would be crushing for me to lose my leg. So I'm like, okay, I guess I'll try. But so he felt it was going to help him, and he felt it could help him keep pressure off some of those other areas. So he, like 15 years ago, had an aneurysm repair. And so doing that maneuver where you go from one groin up and over through a graft doesn't work very well. So I punctured him in I knew because he'd already had an angiogram that his problem was behind his knee. I just punctured him right in his superficial femur with a small catheter and aimed down towards the foot. And so this is his distal SFA, that's his knee joint, and this is his popliteal, and it occludes right in through here. This is not a new problem. So this isn't like that other guy who had a plaque rupture or acute on chronic. This is a chronic problem because he actually these are unnamed collaterals. So that popliteal occlusion's probably been there for a while, but something happened with his positioning that got him into trouble. That's why the other surgeon's like, you know something, you don't have bad collaterals and your ABI is 0.6, maybe you're healed. But he got to me like 3 months later and he hadn't healed. So I punctured and I actually went and put a wire through, that's this segment here, and I did an atherectomy and angioplasty. And so it looked a lot better. I got his ABI back up to 0.9. And in conjunction with the wound center, we got him an offloading boot. He was pretty committed to it. I said, look, if we're going to do this, you have to be all in on offloading. And he was, and we're almost there. And this is where it's a team sport. So the wound center has been, that little yellow stuff there is a cadaver skin. You know, so they've been seeing him weekly. They've been putting cadaver skins on. They've been offloading him. And again, he was pretty happy with what happened. And that was a recent gratifying case for me. So PAD, highly prevalent, often undiagnosed. Diagnostic tests are easy, non-invasive, available in our office, but really you have to look at your local milieu as to what you can get locally. Treatments are there. They're not perfect. I wish they were better, but we do have a lot of ways to treat. You know, the claudicants maximize the medication. If you think that you have critical limb ischemia, try to figure it out fast or send it to us fast. And I'd rather have a false alarm than not have an opportunity to try to save one. So sorry, I'm long-winded.
Thank you for the talk. It was
No problem.
very, very interesting. Question for you. So the procedure you talked about rotary ring and getting blackout. How does that? I mean, because otherwise it would just like travel downstream and include further down. How do you get that out? Like without a
So that it's an excellent question, and that's a problem with some of them. So some of them it'll be like a rotating blade, and at the same time it has suction, so it sucks as you go. There's one that's a small diamond burr that rotates, and it rotates to such a fine level that it passes through the capillaries and just goes. This is where I said we got a million tricks. There's also embolic protection devices. So you go down before you do your intervention, and on the end of your wire, there's a net. And so the net catches it, you have to grab it and pull it out. Those were actually invented or put into use for carotid stenting. So early in my career, when I was getting trained, I was like, oh no, I'm never going to do a carotid endarterectomy because stents are coming. And the trouble with stents was getting from here to here, the stroke rate was related to before you even did your stenting. So then they developed the embolic protection devices. But even still, you had to get your embolic protection device through the plaque and open it before you stented your carotid. So the levels of stroke were too high. Now, we can stent people, but we make a decision here. Instead of putting anything by it, we reverse the flow. So we clamp the carotid and we have a sheath here and a sheath in the femoral vein. Hooked to a pump, it pulls blood backwards. We put it back in their vein with a filter in here and we catch it. So that was an astute question, and there's different ways that we don't use on the leg. The leg is a more forgiving organ than the brain. So if you have some tiny particulate debris, but you've treated an SFA occlusion, you're going to do better. But some people argue that if someone's a bypass candidate, each time you do one of these interventions, you might damage some of their runoff a little bit. And there's some data that says de novo bypasses do better than bypasses after you've had multiple endo interventions, probably because in doing those interventions, you may have damaged some of their runoff.
What about buttock pain?
Sure. Why do you ask? Can you be more specific?
A friend of mine has been complaining of back pain, and I never have associated that with claudication.
Yeah, so it can be from claudication, but it has to be proximal. So is it one-sided or two-sided? If it's two-sided, it could be aortic stenosis, or it could be disease right at the bifurcation, at the aortoiliac bifurcation. Or it actually can also be just disease in their internal iliacs. So it could be claudication. And how do you figure it out? Those people, sometimes if it's subtle and just but a claudication, they can have a normal ABI. But if it's suspicious enough, what I'll then do is I'll do a stress and I'll do an exercise ABI. So we have a treadmill in our office. So if someone has pain that I think is claudication, and their ABI is normal, you have them walk on a treadmill for 5 minutes and get right off. If you measure it again right after, if it's vascular, it'll drop. That's also helpful if you're trying to figure out neurogenic versus vascular. If you're really convinced, sometimes you do need like a CTA or something to figure it out, because it's not that typical, but it could be. Happy to take a look.
But you never forget your first maggots. But for the cilostazol, for the heart failure, what's the contraindication with that? Is there something that you do for heart failure patients instead?
I just don't give it, because it says that it can exacerbate their heart failure, and it helps a little, but it's not often a game changer. So if they have a history of heart failure, I don't give it to them. Have I seen it make heart failure worse? I don't know that I have, but it's the product, the label says don't give it to someone with heart failure.
When you're getting referrals over at the vascular center, do you have like a preference on what you're looking at before? Like sometimes I am setting my patients for ultrasound before, or like put a risk calculator in to just send them over, like please evaluate for claudication.
A nice summary statement.
Just a summary, okay.
And that's mostly because when they come through it with all the different EMRs, sometimes there's 32 pages.
Oh.
And trying to figure out what they're coming for. Because we do, particularly if people come in a distance, if someone says vascular disease, may want to we try to look through and see if maybe they could get their test the same day. So if you say, particularly and we can't really, it's hard to order a test if we haven't seen them, but because it's like a Stark violation. But if you said, I want an ABI, I think they get vascular disease, like a 2-sentence summary would mean the world to me. Because of what comes via the fax and electronics, it's dense.
Ordered stuff before, just to put in the summary to say
But,
like.
yeah, already
this
had
is-
that.
This is done, like check.
Yeah,
Okay,
yeah.
right. So like
Yeah.
sending them over, it's just like, please evaluate, but then, okay.
That's okay too, but if I mean, you guys are all smart, and sometimes one sentence could save me 10 minutes of looking through 30 pages.
We'll take one more.
Can you speak a little bit about your threshold for intervening on carotid artery stenosis? Because obviously we all have a patient like in internal medicine who have pretty moderate, stenosis, and they all have non-specific dizziness on the same.
So dizziness is almost never from carotid disease. So I'm very aggressive with symptomatic disease. I think the data supports being aggressive with symptomatic disease if it's clearly lateralizing to a particular carotid that's more than 60-70%. Asymptomatic disease, I'm not as aggressive about. There's literature that is now getting real close, best medicine versus carotid intervention for asymptomatic carotid disease. The CREST-2 trial just finished enrolling, and it looked at best medical treatment alone, best medical treatment plus carotid endarterectomy, best medical treatment plus carotid stenting. And it didn't end early, and I'm pretty sure it's going to be close. So for asymptomatic disease, I tend to only be aggressive if it's more than 70 and they're young and very fit and vibrant. If they're elderly and asymptomatic, I think medical treatment is actually not a bad option for carotid disease. If someone has a lateralizing symptom though, TIA, amaurosis, then even with a lesser degree of stenosis, I'll be very aggressive. And I think most people that do carotid interventions would say that as I've evolved, I graduated from med school in 1999. Early in my career, and when I started at Maine Med, I was like 2007. I was very aggressive about doing carotid surgery in asymptomatic people, but everybody was. But as statins have come into play, that has changed the medical management for carotid disease. So I'm happy if someone's over 70% and you think they're a candidate and they're young and vigorous, I might treat them asymptomatic, but and any symptomatic, even if they're elderly and frail, because it's such a better predictor. The degree of stenosis is just a proxy for plaque, but it doesn't predict whether it's going to rupture. And patients come scared. I got an 80% blockage, and I say, well, I say to them, the stroke doesn't come from not enough blood getting to the brain. It's when it breaks off. So if you had a 60%, you just had a TIA, that's a hell of a lot more scary than a 80% in an 80-year-old who's never had a symptom. Does that answer your question or no? Welcome. Hope that was okay.